This conference will now be recorded.
Morning everyone, I'll start the class in 5 minutes. Please log in quickly. Starting the class. Today's topic is about a very interesting disease, that is thoracic outlet syndrome. So, this is often most commonly misdiagnosed entity. So the patient with thoracic outlet syndrome can be misdiagnosed with a spondylosis of the neck or a shoulder pain, lymphatic of the left right upper limbs, showing the proper, etc. Because it is commonly misdiagnosed. For anatomy and the various degrees of present terms, identify thoracic. These are illustration cases, scenarios where the patient presents. So this is one of the that's where a 32-year-old female with a 6 month history of parenting sensation in the left upper limb. So what she comes is difficult in tasks that all raising her head above the head. So most commonly, any general practitioner might just diagnose it as a frozen shoulder or something related to the shoulder. So but that is not the case. This is due to thoracic outlet syndrome. So while examining the patient, you will find a mild neck tenderness. There is no neurological deficit. Pulses are felt, which rules out as an arterial disease. There are certain tests present in thoracic outlet syndrome, like the Addison tests and Allen's test, etc., which are important in diagnosing it from. There are three different types of neurological deficits present in the thoracic outlet syndrome. Those are neurogenic, which institutes about 90% of the cases. There is arterial TOS and the venous type. So depending upon the vessel or structure involved, it is differentiated into neurogenic, arterial, and venous. So most common is always neurogenic. So what you do is you order a X-ray of neck to see what is the predisposing factor. So here you can, I don't know if you can make out, but these are the cervical ribs. So here is the first rib, but this patient has a bilaterally extra cervical rib. So that causes a compression features on the structures present in the tunnel. So this leads to the pain and the symptoms. So this is another case scenario with a similar, but in the first case you are seeing a neurological symptom. And here you are seeing a arterial phenomenon, where a 20-year-old female or 20-year-old MBBS student, for example, presents to you with a Raynaud's phenomenon in the left hand since 1 year. While examining, you see the left upper limb pulses are not felt. So again, here you can see a cervical rib present in the X-ray. This is angiography revolving. It shows a compressive feature here. So I am going into the topic in proper. So by definition, it is defined as a spectrum of disorders caused by compression of neurological, arterial, or venous structures traversing the cervicoaxillary canal. So the canal in which the structures pass is the cervicoaxillary canal. So when coming to the epidemiological factors, incidence is about 1 to 2% in the total population, usually seen in females. It's a ratio of 3:1. So in that cervicoaxillary canal traverses the subclavian artery and vein, and brachial plexus also pass through that cervicoaxillary canal. So these are the structures that are present in the canal: subclavian artery, subclavian vein, and brachial plexus. This is the space. There are 3 canals here. The important one are the interscalene triangle. That is, these are 2 scalene muscles, anterior scalene muscle and posterior, the middle scalene muscle. Between them presents the interscalene triangle. This is the most commonly involved space. Through this passes the brachial plexus and the subclavian artery. So about 90% of the cases presenting TOS are always due to interscalene triangle complaints. Then there is the costoclavicular space. So it is formed by the clavicle. It is formed by the clavicle, first rib, and superior border of the scapula. So posteriorly scapula is present. With that border, the costo-clavicular space is formed. In that, subclavian vein is traversing in that space. And there is pectoralis minor space. There is nothing that is passing in that, but it is important for the theoretical purpose. Important ones are always interscalene triangle and costo-clavicular space. So as I said earlier, there are three forms of presenting features that are neurogenic, arterial, and venous. So neurogenic comprises about 90 to 95%, and venous comprises about 2 to 3%. Arterial is 1%. Whenever there is an arterial symptom, it is always an emergency. We should identify and intervene as quickly as possible. So neurogenic TOS is commonest, and women of third to fourth decade of life are commonly involved. The main presenting feature is the pain and paresthesia. So when I'm discussing the case scenarios, I have said that this is a diagnostic challenge because this pain mimics several other types of orthopedic complaints or CNS complaints. So patient, you don't always come into suspicion that it is a TOS. So knowing about TOS is important to have a in the back of your head. You should always be suspicious about TOS. Whenever a patient complains about upper arm paresthesias or pain. So the clinical signs are the supraclavicular space tenderness. So if you palpate the patient with a TOS in the supraclavicular region, there is a tenderness elicited. And there is Tinel sign. Tinel sign is, can anyone say what is Tinel sign? Has you ever heard of it? Anyone? Tinel sign is nothing but paresthesias. Paresthesias when you percuss the patient's nerve. So if you are percussing in the supraclavicular region, or where the brachial plexus are traversing, you can elicit paresthesias in the where the nerves are distributing. That is commonly the arm. Tinel sign may be present. It's not by default the most important sign, but they may be present. Then comes the elevated arm stress test, that is the Roos test. What you do here is you hyperextend your arms and do a clutching motions. So you clutch your arm and release it. So while doing repeatedly, this causes paresthesias and pain in the affected side. So that is more reliable while clinically examining a patient. So in clinical practice, always it is important to diagnose a disease based on your clinical knowledge. So these tests always help you in diagnosing it. There are others where you go for investigations, that is Dopplers, nerve stimulation studies, etc., which give you a confirmatory diagnosis. But your diagnosis should always be based on clinically. Even before ordering a test for radiological examinations, you should always come to a conclusion that this is probably this disease. That is why you are studying this much of a course of about 5.5 years and again PG of 3 years. This is to improve your clinical knowledge. Then there is the hyperabduction test, where that hyperabduct the upper limb and do an external rotation with the forearm. So this causes paresthesias in the ulnar side of the arm. So this also may lead you to a diagnosis of TOS. And this is the Adson maneuver. These are the several tests that you do for diagnosing a TOS without ordering a radiological investigations. So this is Adson's test or Adson's maneuver. It is called. So what you do in Adson test is you always rotate the head from the affected side. So if your right hand is the affected side, you turn the head to the left hand, hyperextend the neck. And you ask the patient to inspire and expire. This leads to a pain in the affected side with decreased pulses. So some people can do might do this with a manometer, but that is not usually indicated. You can also elicit a wasting of intrinsic muscles of the hand. In a patient with long-standing TOS, what happens is due to the decreased nervous stimulation, there is always a muscle wasting present in the hand. So diagnosis is always made based on the clinical knowledge and above mentioned tests that are Adson's, and Adson's maneuver, Allen's test, and hyperextension, etc. So to rule out other conditions, the most commonly misdiagnosis or most common differential diagnosis are cervical disease or carpal tunnel syndrome. They may give you the same type of presentation. So conservative management, coming to management, always be based on a step ladder pattern. That is, always be first one should be conservative. Then comes the medical management. So medical management, sir, what you do for pain? That is that might only cure the symptoms, but that does not cure the disease. So the main treatment is surgical, that is decompression. So as the triangle is reduced and causing compressive symptoms, the treatment of choice is decompression. You either do a to remove the compressing rib or the muscle. Coming to the treatment of neurogenic TOS, always you should strengthen the back muscles, that is trapezius and levator scapulae. So strengthening that muscles puts a lesser load on your cervical muscles. So physical therapy and to improve the ergonomics, you do the strengthening exercises. So that is followed for a period of 6 weeks. So if there is improvement, you should these improvements, that is daily exercises and to work in a better ergonomics, that is seating positions and how you keep your head positions during work or etc. So that is a conservative management. If there is no improvement, botulinum injection and electrophysiological fluoroscopy guidance may reduce the symptoms. But botulism injection is not that popular because there is only reduction in symptoms for about 2 to 3 months. After 2 to 3 months, it again reappears. So it can be used for symptomatic management or in the patients where surgery is contraindicated. That is more than 70 or 80 years of age, where surgery in itself causes more damage than doing nothing. So in In that patients, you can try botulism injections or scalene block. That is, you inject lidocaine into the scalene muscle. So this causes temporary neural blockade. Then comes the surgery, that is transaxillary first rib resection. This is the decompression surgeries. It is transaxillary first rib resection. This route is, there are two types of routes where surgery is done. One is transaxillary and other is the supraclavicular. So you resect the rib here. Then if that is not possible, resecting the rib is not possible, you should consider scalenectomy. That is, you excise the resect the scalene muscle, and, which create a more space to the triangle. So there are two approaches, that is transaxillary and supraclavicular. Transaxillary gives better exposure of the anterior end of the first rib, the subclavian vein. So through this approach, scalenectomy can also be done, but the main advantage of transaxillary approach is it gives better exposure of rib and the subclavian vein, whereas the supraclavicular approach gives a better view of the scalene muscles. And so scalenectomy can be done better in supraclavicular approach, and it also gives you a better exposure of brachial plexus. So this is the transaxillary approach where incision is under the arm. So after opening, you can see this is the first rib and this is the cervical rib. So this cervical rib is causing compressive symptom in the scalene triangle. Normally, in every one of us, this cervical rib won't be present. That is why there is no compressive symptoms. When the space is occupied by other things like the muscular, there is hypertrophy of scalene muscles or cervical rib. This causes the space to narrow. This is the transaxillary approach where you can see this is the rib, first rib, which is being resected. This is the first rib. So here you can see pre-op and post-op images. Here the rib is resected. So here you can see the right side cervical rib. Here there is no rib. That is post-operative change. So then comes the second type of POS, which is about 2 to 3% of patients seen in TOS. So this is always secondary to underlying bony abnormality. So if there is a patient presenting with thoracic outlet syndrome and with absent pulses, you should always be suspicious of a presence of cervical rib. Cervical rib can be of complete or incomplete rib. So what is complete rib is, it will form as a like any other 12 ribs where you can see complete cartilaginous and bony parts for a rib. While as an incomplete, it is a freestanding and is freely in the air. It won't have a cartilaginous part, only bony part will be there. So it can be seen in both type of cervical ribs. So the most common presenting symptoms are the ischemia, thromboembolism, and Raynaud's syndrome, and subclavian artery aneurysm. Due to constant pressure on the subclavian artery, it can give rise to an arterial aneurysm. So diagnosis is again based on the clinical tests which are discussed in the neurological part. And cervical rib can be diagnosed by an X-ray of the neck. Then comes the radiological part, where you go into interventional radiology, where angiogram is used to know the flow of the subclavian artery, whether it is obstructing it or not, and duplex ultrasonography. This gives you a flow of to and fro flow of the blood in the arteries and veins. Again, the treatment is the same. Supraclavicular approach, where you access the first rib. If it is in an inoperable state, you can always try a arterial bypass, where you bypass the obstructing region to maintain the patency of the artery. Then if there is an aneurysm, which is present in very rare cases. So in aneurysm, to go for an aneurysm repair, that is either embolization or a bypass. Transaction. This is a supraclavicular approach. So coming to the venous type of TOS, so it is also called as Paget-Stoddard syndrome. The main vein that is the cause of the venous TOS is the subclavian. It can also cause axillary artery thrombosis. So like any veins which causes compression, there may be a features of DVT. So the limb might be edematous, the loss of hair and shiny appearance, and there will be severe pain all over the upper limb. So that might be caused due to the deep vein thrombosis. So the diagnosis is always with duplex ultrasonography, and the treatment is first you always try for a thrombolysis and anticoagulation because there is a thrombus present. So after that, there is an improvement in the symptoms. Then we go for the decompressive surgery after 3 months to prevent recurrence. And coming to the etiological types, there are based on anatomy and muscle anomalies. So in anatomy defects, there are the cervical rib, which I have already discussed, which will be resected during surgery. And there are also other deformities where long C7 transfer process, C7 vertebrae has a transfer process. If it is too long, it can also cause a compressive symptom. So there, in some patients, there will be abnormal ligaments or bands present in the triangular region. So that might also lead to the common symptoms. And coming to muscles, as there is scalene muscle hypertrophy, I have already said that. And so it can be an anomalous insertion of the scalene muscle or an scalene muscle hypertrophy. These are two entities. So again, coming to the nose can develop tumors. So there may be a tumor present in that region or an aneurysm present in that region, which gives more compressive symptoms. Other etiological factors are like trauma. So trauma can cause, for example, in a car injury, in a road traffic accident, where you have a whiplash injury. You might have heard about a whiplash. Due to that effect, it can present into a TOS. And posture is always important, and due to poor posture, some people have the tendency to for drooping shoulders, and uh, neck is always in an forward position. So in this generation, it is more common because of use of cell phones and computers. Drooping of shoulders and holding the head in a forward position might lead you to a TOS in the long term. So, and there are other factors like in sports, for example, swimmers and baseball pitchers. You might know, boys might know baseball pitching. The baseball pitchers always throw the baseball, so they might have a more TOS symptoms because they're always in a repetitive motion, repetitive. Uh, these repetitive motions cause injury on a long term basis. This is a scan of duplex ultrasonography. So here you can see the subclavian vein, brachiocephalic vein, and the internodular vein. Here you can see biphasic flow of a subclavian vein. These pictures are not that important to you, but just remember how a duplex scan looks like. So that is in brief about TOS. Do anyone have any doubts regarding TOS? So, coming to summary, always remember it is first and mostly diagnosed by clinical parameters. So remember the tests which are important in this, that is Addison's test, Allen's test, uh, hyperabduction test, which is named after Wright, WRIGHT, Wright's hyperabduction tests, the Addison test. Any doubt? So any doubts? So what are the surgeries that we do for TOS? So what are the surgeries that we do? TOS is not that difficult to remember. So if anyone asks what is the surgery, just say decompressive surgeries. So then he might ask what are the decompressive surgeries? That is scalenectomy. So everything is in the anatomy. Every answer for your questions is present in the anatomy of the triangles. So it is formed by the cervical rib or the first rib and scalenus anterior and scalenus medius muscles. So if anything happens, that happens in that region and surrounded by those muscles only. So the answer is always decompression surgery and based on the structure involved. So it can be scalenectomy where you exercise the muscle to create space, or you can go for a rib resection. So that are the surgeries that we do. And there are advanced surgeries where you go for bypass and embolization for aneurysms, etc. But at this level, always remember that just decompressive surgeries. That's it for today. So, thank you.